I'm glad that Dr. Kyle was here to give us the 50-year perspective, because we did just recently update our look at the Mayo Clinic myeloma population as shown here. And this, I think, is a very nice slide to look at the dramatic progress that has been made over the past 10 years, and even over the past 5 years if one looks at the 2005 to 2010 diagnosed patients. A lot of this advance can obviously be attributed to the introduction of new drugs, and particularly the proteasome inhibitors. So I thought I would show you one slide from the laboratory which was done after the fact. We already knew that proteasome inhibitors were active, but we did a RNA interference screen on myeloma and asked what are the most lethal genes that when silenced kill a myeloma cell. Now if you read very quickly, you'll see there are about 30 genes on there. The most potent, if you're interested, is MCL1. However, amongst the top 30 genes, the most prevalent family, as shown there, were about 6 members of the proteasome family. So had we done this before Velcade, we'd have looked very smart. Since we did it after Velcade, we just said this was a validation of our experiment. But it does point to the fact that this is an incredibly important pathway in the plasma cell. Now, just to recap some of the things we've learned. First of all, if you look at induction chemotherapies, the big jump in the blue, and which is partial response rate, and the green line, which is complete remission, happens when one introduces Velcade or bortezomib or one of the newer proteasome inhibitors into the mix. Now, it doesn't seem to matter too much what you combine with a proteasome inhibitor when you're newly diagnosed. In the evolution study here, we looked at whether combining lenalidomide, cyclophosphamide, or both drugs made a difference. And certainly in terms of response rate, there was absolutely no difference whether you use Cytoxan or lenalidomide, except in your pocketbook. We learned, as was shown earlier, that if you combine a proteasome inhibitor with conventional therapy, that you live longer, as shown by the VISTA trial. And we learned, as also alluded to earlier, that if you continue therapy longer through a maintenance protocol, as shown here by Dr. Palumbo, that you can also extend progression-free survival. So using a proteasome inhibitor early in combination and for longer seems to be of benefit. It seems to be of particular benefit in higher risk patient populations. This is the HOVON trial here, and I've highlighted for you in the red box the high-risk T414 and deletion 17 population. And I'll draw your attention, this trial used bortezomib throughout versus a thalidomide-based maintenance therapy. And you'll see here that for the high-risk P53 deleted or 17P deleted patients, overall survival at 3 years was quite dramatically improved from 17 to 61%. What else have we learned? One of the things we learned, unfortunately, of course, was that when one uses a proteasome inhibitor such as bortezomib, and particularly when you use it for longer periods of time, that toxicity and neuropathy become problematic. So we learned 2 other important things about reducing toxicity. First of all, that you could, at least when used in combination, give the drug once weekly instead of twice weekly and lower toxicity substantially. And we also learned from a study from Dr. Moreau in France that you could give the drug subcutaneously and presumably because of a slower absorption and higher peak levels, reduce neuropathy rates. It's important to point out, however, that we have never seen any data yet on using subcutaneous bortezomib once a week. We don't really know what that will do. I think it has become relatively standard practice. My bias is that that is essentially giving a lower dose of bortezomib and that we will see some consequence with respect to depth of response by doing that. But if you're not in a hurry and your patient's particularly elderly and toxicity is a big concern, I think weekly subcutaneous dosing is very acceptable. If you need a rapid response, you're in renal failure, or you really do care about the depth of response, I would be inclined to stick with a higher dose weekly IV or twice weekly sub-Q. We have some new proteasome inhibitors. Carfilzomib has a different binding moiety. It's an irreversibly bound inhibitor. As you're aware, it is probably the most active single-agent drug in myeloma that's been reported, with an overall response rate in early relapse bortezomib-naive patients of 55% as a single agent, and if minimal responses are included, 62%. We also learned quite early on that this drug does not cause peripheral neuropathy almost ever. However, there is a fluid retention syndrome that happens with this drug, which I think is still being sorted out. I don't believe personally, and we have data to I think show that this is not a cardiomyopathy, but there is very clearly a syndrome where fluid is retained, blood pressure goes up, BNP levels rise, that still is in evolution. We're waiting with carfilzomib for the results of the ASPIRE trial. I think it's an important study. It will teach us a lot about lenalidomide and low-dose dexamethasone in the relapse setting, and it will tell us about toxicity, since it's a randomized phase 3, and it will tell us whether the three-drug cocktail is both safe and effective, and it looks like we will be hearing the results of this trial later in the year. This is one of my favorite slides. Some of you have probably seen it before. I had a summer student, I asked her to go through the literature. She found 400 drugs that were active in the lab, probably about 50 from my lab and about 250 from Ken's lab. Of those, 129 drugs had made it into the clinic, so a fairly high percentage in 228 clinical trials. So I asked the student, I said, just plot out for me the partial response rate for every drug and put it on a piece of paper. And then let's look at the last FDA-approved drug, which is here, which is doxorubicin, and one can argue whether or not that's a particularly effective drug. And then let's look at what's more active than doxorubicin: melphalan, lenalidomide, dexamethasone, carfilzomib, thalidomide, pomalidomide, bortezomib, cyclophosphamide, daratumumab, prednisone. All the FDA-approved drugs. Notice that there is no FDA-approved drug on the right-hand side of this slide. And the reason I show you that is to point out that some of the drugs that you're going to hear about tomorrow and in a few seconds do fall just slightly below this line down here, and you can pick your favorite drug out of the list. This is an imperfect analysis. It covers 50 years of clinical research. It covers time periods where bortezomib and lenalidomide did not exist, but I think it's a provocative slide. None of the reviewers liked it anywhere, so thank you, Clinical Lymphoma and Myeloma, for finally accepting it. It is out now, and I think it's actually pretty useful. I use that to introduce to you the two new oral proteasome inhibitors. First, ixazomib. This is basically somewhat similar to bortezomib orally. The reason I show you the slide before is that if you looked at phase 1 data for 50 response evaluable patients, about 30% had a minimal response and 18% had a partial response of 50% or less. So this is falling very close to our cutoff of 20%, which is the sort of theoretical single-agent activity we'd like to see for a drug that will get FDA approval. And of course, if we look at the combination of ixazomib with lenalidomide dexamethasone in the newly diagnosed patient, this looks like a very potent drug in combination, and I think we have some optimism that this will indeed prove to be successful in phase 3 clinical trials and potentially change the treatment paradigm by offering a completely oral induction therapy. Oprozomib is, let's just call it, an oral version of carfilzomib. It also appears to meet that threshold. In 12 myeloma patients in phase 1, the overall response rate was 25%, very small numbers. And as you heard from Dr. Treon earlier, or perhaps we didn't, but it's true that in 5 Waldenstrom's patients at least, the overall response rate was 80%. The problem with this drug is likely to be upper GI toxicity. It turns out to be somewhat difficult to tolerate and perhaps is associated with some more serious effects that are now emerging. I wanted to close by going back to the lab and to tell you of all the things we've learned in the last 10 years about using these drugs clinically, we've also made progress in understanding their biology in the laboratory. And I'm going to share with you a paper that Roger Tiedemann, who's now in Toronto, and I worked on together, but Roger gets all the credit because he did all the hard work after he left us. And the bottom line of this paper, which I'll explain to you, it's a little bit complicated, but he shows that loss of the gene products of IRE1 and XBP1S confer proteasome inhibitor resistance. That this high immunoglobulin production confers sensitivity, that low IRE1 XBS cells, i.e. proteasome inhibitor resistant cells, are actually pre-plasmablasts. They don't look like your conventional plasma cell under the microscope. And that these clonal myeloma progenitor cells survive proteasome inhibitors and contribute to relapse. In other words, these are the cells that the drugs are missing that we now have to focus our attention on going forward. And it is a little complicated, so let me just tell you in a couple of slides what I'm talking about here. This is the worst cover ever published, by the way. Apparently, Cancer Cell make you design the cover yourself. And Roger and his wife did this at the kitchen table, but it's supposed to be, this is bortezomib, this is your myeloma plasma cells up here. You'll see them sitting here, and these are the roots below the ground, which the drug is failing to get. Okay, here's what we did. The science is actually quite nice despite the cover, which is good for illustrating the point. We did this RNA interference screen again. I showed you the result with the proteasome inhibitor before, but we also did the experiment in the presence of bortezomib. And then we asked, when you silence a gene, what makes you really sensitive to bortezomib? And I'm not going to talk about that tonight, but there are things. But if you silence a gene, what makes you profoundly resistant to bortezomib? And we did it with two different experiments here. And you see that at both ends here, one of the genes that makes you most resistant to a proteasome inhibitor is this IRE1. What is IRE1? Well, it is part of the unfolded protein response, and it's required to splice XBP1 into its active form. Now, if you have no XBP1, you don't make any plasma cells, so that is absolutely required for plasma cell development. And IRE1 is therefore absolutely required for plasma cell development. And this is the complicated slide, but basically Roger was quite smart. He took 3 different patients with 3 different types of myeloma here, and he showed by FISH that you can actually track the genetic aberrant cell right back to a B cell, which is CD20 positive, stained in yellow, and the FISH translocation is still present. He then took a traditional plasma cell here, CD138 positive, and stained it for X-box binding protein 1, and there it is in pink, staining. You'll see that is lost as you de-differentiate the cell. So B cell goes to activated B cell, pre-plasmablast, and then on to this mature plasma cell. XBP1S goes progressively down as you do that, but these are all part of the malignant clone. Then he took a patient and he just quantitated the number of these cells in that patient over time as they were treated. And you'll see that they're newly diagnosed, almost all the cells are classic plasma cells. Lots of XBP1. You would think myeloma, that's going to be very sensitive to a proteasome inhibitor. And in fact, that's what happens. So here's his patient, and most of these cells go away quite quickly. Patient relapses. Now they're still there, but what we're seeing is more of these. Now these will still be somewhat proteasome inhibitor sensitive, but there's less of them. But what's important here is as the patient becomes totally resistant to bortezomib-containing regimen, you'll see that there are no traditional plasma cells. Immunoglobulin levels drop, right? That's what we see in end-stage myeloma. They don't make immunoglobulin anymore. That we've known clinically for years. And now what we're seeing is a preponderance of these very early cells, proteasome inhibitor-resistant, early-stage B cells, IRE1 and XBP protein low. So that, I think, scientifically is probably, in my opinion, one of the more important advances that have been made in the field in the last decade. And this just shows it schematically here. Newly diagnosed, lots of traditional plasma cells in remission. You can't see them anymore, but there's a residual progenitor cell clone. And at end-stage disease, we see mostly these cells emerging. They're proteasome inhibitor resistant. That's the end of my talk. I'll just summarize it for you. What we've learned in the past decade is that bortezomib extends survival. It's safer at lower intensity, weekly, subcutaneously, and when used in combination, but perhaps maybe slightly less effective. Longer duration of bortezomib likely helps and potentially, or at least partially ameliorates high-risk disease, but does not overcome it. Carfilzomib is FDA approved and is being employed earlier and in combination. It does not cause neuropathy, but it does cause this fluid retention syndrome. Oral proteasome inhibitors are active, but upper GI toxicity in particular may be limiting. And finally, I think we've begun to understand at least one of the mechanisms of proteasome inhibitor resistance, which is this unsensitive myeloma progenitor cell.